My name is Zev Wainberg from UCLA, and I'm here to talk a little bit about the selection and sequencing of therapy for patients with metastatic pancreatic cancer. And the way in which, obviously, one of the great ways to discuss the data is to use case examples. So our first patient is a 63-year-old diabetic who presented with abdominal pain radiating to the back and about a 10-pound weight loss. On exam, the patient was icteric and jaundice, and the lab showed a bilirubin of 4.5 with an albumin of 3.3 and a mildly and essentially normal transaminases. The scan showed a 4.5 by 4 centimeter mass in the head of the pancreas with intrahepatic biliary ductal dilatation. Unfortunately, beyond that, there were multiple suspicious hypoattenuating lesions in the liver, which were up to 3 centimeters in size and very classically consistent with metastatic pancreatic cancer. An ERCP was done for hyperbilirubinemia and worked and was successful, and a placement of an indwelling plastic stent resolved hyperbilirubinemia, and a biopsy at the same time confirmed adenocarcinoma. And the patient, as is typical, only had a fine needle aspirate done of the material, so full genetic sequencing was unable to be performed, but the biopsy was histopathologically and immunohistochemically consistent with metastatic pancreatic cancer. Germline testing was done that showed no significant abnormalities. And so the patient was a patient of mine at the time who we enrolled in the NAPOLI-3 trial, which was, as we'll talk about, a large randomized phase 3 trial. The patient was randomized to the experimental arm of that study, which was the NALIRIFOX regimen. And after the first scan, which was at 2 months, he had a nice response and was already responding clinically with a improvement in some of the weight loss and abdominal pain. As is typical, by 8 cycles in, he started to develop some peripheral neuropathy. We'll talk a little bit about that later. And the oxaliplatin was dose reduced. And then it got a lot more difficult over time, and ultimately, when the oxaliplatin symptoms start to linger into your off-treatment week, we made the decision to discontinue the drug and was placed on maintenance FOLFIRI, or in this case, because it was on the study, of course, it was NALIRI. And his CA19-9 had been stable and dropping, but by 12 cycles, which is about 6 months on therapy, he's now started to show increased biochemical markers of CA19-9, and CAT scans confirmed disease progression. Excuse me, CAT scans continued to show stable disease, but there was some concern over disease progression. At that time, and the patient was on a protocol, but this is done obviously pretty commonly, the neuropathy was stable, not getting worse, and we made the decision to bring back the oxaliplatin at a lower dose, half the dose, essentially.
Could I just interrupt you for a second before you keep going? Could you just let us know what the current status of the patient is? What happened?
Yeah, so this patient is 2.5 years ago. So ultimately, the patient did pass away. Patient got maintenance chemotherapy, and for a little while, actually, the disease stabilized again. So the 19.9 kind of went up a little and then started to trickle down and stabilized and plateaued. The patient then progressed ultimately 3 to 4 months later and was started on Gem/Nab-Paclitaxel second-line therapy, but did not have any response to that, unfortunately. And then gradually started to obviously progress, and then the decision was made to initiate hospice care. So the patient ended up living about 15 months overall from the time of diagnosis, approximately, but didn't get a lot of mileage, unfortunately, out of second-line therapy.
Just curious, you mentioned that I guess the patient turned down a biopsy, so initially you didn't have the NGS. Did you ever get NGS, and did you ever do a liquid biopsy?
We did a liquid biopsy. We did not ever, a patient did not want a repeat biopsy. Patient was pretty well educated, interestingly, and really didn't see the value. And we ended up doing circulating tumor DNA, which did not reveal any significant abnormalities that were actionable. And by that, I mean he did have a KRAS G12D mutation and a P53 mutation, but no what we would consider to be actionable material came from that circulating tumor DNA.
How comfortable are you just with a liquid biopsy in terms of, ruling out, a genomic abnormality such as BRCA that might respond to PARP?
And so in patients that have, no BRCA mutation in the germline, and then they have it in the tumor, which is, I think, what you're alluding to. It's not even clear that those patients get a lot of mileage out of PARP inhibitors, to be honest with you, Neil. And so I do think that's still an open question. I mean, I do prefer to have tissue, because I think tissue can, you're finding the one-offs that you might not pick up by a circulating tumor DNA. Certainly, you're going to get comprehensive DNA and RNA if you send it for the right assay, that you're not going to pick up any of these fusions or any of these other abnormalities that are very, very rare but meaningful. We can do, I think the majority of testing is available on ctDNA, certainly for the common genomic stuff and the MSI-high information that we always like to get. So it really depends. I prefer it, but sometimes it's just not possible.
Do you consider pancreas a tumor that sheds a lot? You have high levels of positive liquid biopsies or not?
Absolutely. I think that the majority of pancreatic cancer studies have suggested that there is a very high correlation on the frequent mutations that we see in the tumors corresponding with circulating tumor DNA. And that includes the classic ones like KRAS, P53, P16. Those very, very commonly will pop up on a ctDNA, on a quality ctDNA assay. So I absolutely think that while not perfect, it has a high degree of sensitivity for the most common alterations in this disease.
I know we're going to be talking about sequencing of therapy, and Eileen's going to get into the PARP, but I'm just kind of curious what your take is of the use of PARP or olaparib as maintenance. Is that a strategy that you use if you do have a patient who has a appropriate mutation?
Yes, but very selectively in my experience. So I use olaparib in the context of usually germline patients that have BRCA 1 or 2, or even, to be honest with you, I have a patient with germline PALB2 that I've utilized olaparib there as well. But I don't do it at the point of progression anymore. And I think so in the study, obviously the POLO trial, there's some value to maintenance olaparib. And I think even in that context, you have to be selective about which patients to utilize it in. That's what I've learned over time. So really at the low point of their disease, so to speak, would be, in my thought, the best utilization of that drug.
So does that, I'm not clear, does that mean you use it as maintenance after chemo, or when?
Right, maintenance after chemo in the patients that have had a nice response, who have had less bulky symptomatic disease. In the patients that have BRCA cancers and have a very mild response and are still left with a high burden of disease, I am somewhat reluctant to use olaparib in that context because I still feel like the chemotherapy is essential at that point.
One of the reasons I'm asking is we're just about to send out one of the things we're going to do in the webinar is, we're going to do a survey of you and Eileen and then 4 or 5 other investigators. I'm just kind of, and one of the things we're going to get into is what people do in terms of PARP. I was just curious. I know you're not talking about it. I was curious about your thoughts about it. But I guess my question is, we were thinking about this for the survey. If you know you have a patient with a BRCA mutation, is it the only thing that's, and again, kind of putting reimbursement aside, is the only time that you're going to think about using changing your therapy in metastatic disease, or would you change? I know there's like an adjuvant trial out there. Would you ever change what you do if you knew the patient, for example, had a BRCA mutation? Even choice of chemotherapy, would anything be different
Right.
if you knew that? Everything from
Um,
neoadjuvant up until metastatic.
yeah, for sure. I mean, I definitely use that data to inform frontline decision, in my view. I happen to use a lot of GemCis for BRCA patients with newly diagnosed metastatic pancreatic cancer, and Eileen obviously has published, a lot of people published on that regimen, and I feel that in the right patient, maybe just as good as, let's say, a FOLFIRINOX type of regimen. I don't utilize GemCis outside of the BRCA patients, so I definitely use that information to guide frontline therapy, and not just in metastatic disease and locally advanced disease as well, if you happen to have one. Adjuvant's a little trickier. I find that in the adjuvant context, we really don't have data yet, and I don't feel it's adequate to replace chemotherapy at this point in the adjuvant context.
Does it change the type of adjuvant therapy you use? You
Well, it's
use
got to be
GemCis?
platinum based. No, I'd still use FOLFIRINOX in the adjuvant setting in the majority of patients. I mean, it's got to be platinum, obviously, with those patients with BRCA, but um, you know, I've used mostly FOLFIRINOX in the adjuvant setting there.
All right, please continue.
Okay. So selecting the optimal frontline therapy has been a topic for a number of years, and there's many variables, and one of them is certainly age. Some of the original FOLFIRINOX studies excluded people above the age of 75, so we had limited data from that patient population in that context. We'll talk about that a little later. And obviously, this is a review article that gets into the choices that are being made on a daily basis by our practitioners about what treatments patients ought to receive based on performance status and age. We know for about a decade that both FOLFIRINOX and Gem/Nab-Paclitaxel have become standard frontline therapies for metastatic pancreatic cancer based on these two trials. Both showed superiority over gemcitabine as the control arm. They both came out around the same time. And you can see here, these are the Kaplan-Meier curves for the top trial, which is FOLFIRINOX versus Gem, improving survival by a few months, and PFS as well. And very different trials in some respect. The bottom trial, which was Gem/Nab-Pac, the MPACT trial, was a global study, a community-based study, a bigger study, and the FOLFIRINOX PRODIGE trial was a French trial that was primarily done in academic sites in France, and also did have some exclusionary characteristics like age. Patients were not above the age of 75, for example, and so it was a little more restrictive, I would suggest. But both showed superiority over gemcitabine. And for the better part of the decade, we have been choosing between those two, depending on variables such as what toxicity is preferred, recognizing that neutropenia was perhaps a little more common, and cytopenia is a little more common in the MPACT study, particularly if we didn't use growth factor. But recognizing that neuropathy was a little more common in the FOLFIRINOX arm because of oxaliplatin and GI toxicity as well. So it became this discussion, a trade-off in essence of toxicity profile versus efficacy, and a lot of cross-trial comparisons were done. The NAPOLI-3 trial was the first large randomized phase 3 trial to ask the question of which is a superior frontline regimen. The control arm here was the Gem/Nab-Pac regimen that was established on the MPACT study, and the investigational arm was NALIRIFOX, which of course is a similar regimen to FOLFIRINOX, with the exception of, instead of irinotecan, liposomal irinotecan was used. The dosing is different in the NALIRIFOX regimen because the phase 1 study that established the safe and tolerable dose was at doses that are a little lower than FOLFIRINOX, including oxaliplatin at 60 milligrams per meter squared and the liposomal irinotecan at 50 milligrams per meter squared, which are both less than the approved indications of those drugs in different regimens. The trial was a very large global trial, very similar to the MPACT trial in its enrollment, which meant global, community-based, all over the world, not in academic sites, and enrolled a total of 770 patients. And the trial primary endpoint was overall survival. It was powered to show an overall survival improvement, and the data cut that we presented was from last year, and this was originally presented at ASCO GI 2023 in January. And essentially, the characteristics of the study are shown here. It was a very large study. The study was well balanced for age, gender, ethnicity, ECOG performance status, global region, which about a third came from North America, and essentially was well balanced for all the baseline characteristics. And the trial did meet its primary endpoint. The primary endpoint, again, was overall survival. It did meet the primary endpoint with a hazard ratio of 0.83 and a p-value of 0.04. You can kind of see in these curves what tends to happen here is not uncommon. You get a little separation start to occur at about 4 to 6 months, and it stays slightly separated throughout the duration of the study. The median survival improvement was about 2 months, from 9.2 months to 11.1 months with the NALIRIFOX regimen. In the subgroup analyses, the majority of the stratification factors and demographic factors favored NALIRIFOX over Gem/Nab-Pac. And the progression-free survival was also significantly improved, with the PFS here of 7.4 months. So that's the highest PFS reported in a randomized phase 3 trial in pancreatic cancer of 7.4 months. Keeping in mind this is investigator review, not central. With Gem/Nab-Pac having about 5.6. Here the hazard ratio of 0.69 and the p-value also met statistical significance. And here all of these subgroup analyses, of course, favored NALIRIFOX over Gem/Nab-Pac. So looking at response rate, which was a secondary endpoint of the study, again, investigator-reviewed response rate reported a 42% response rate, so also higher than almost any other study has reported in metastatic pancreatic cancer in frontline in a large global phase 3 trial, 42% response rate compared to 36% with Gem/Nab-Pac. About half the patients in both arms received subsequent second-line therapy or subsequent therapy, which was almost exclusively the opposite of what they received, although a lot of variation took place in the study. In the Gem/Nab-Pac arm in second line, they got all sorts of different 5-FU combinations, including FOLFIRINOX, NALIRI, FOLFOX, FOLFIRI, you name it. And in the group patients who started out with NALIRIFOX, a lot of them got Gem-based derivations, which included gemcitabine alone, Gem/Nab-Pac, you name it. There was a lot of mishmash going on there in the second and subsequent lines, and about half the patients got some therapy. It was a similar toxicity profile if you look at it globally, which meant almost the same number of patients had SAEs and treatment-related adverse events that were grade 3 or above, very, very similar. It really boiled down to a difference in toxicity profile. Interestingly, we saw a lot more cytopenias in the Gem/Nab-Pac arm, neutropenia, anemia, and thrombocytopenia, all grade 3, which led to dose reductions, dose delays, which is typical in that regimen. With the NALIRIFOX arm, we saw a lot more GI toxicity that was grade 3 in nature, so more diarrhea and more nausea. Peripheral neuropathy actually was one of the interesting finds of the study. It actually is a little less common in NALIRIFOX than Gem/Nab-Pac, almost certainly owing to the lower dose intensity and lower accumulative doses, I should say, of oxaliplatin in the NALIRIFOX arm. And certainly a lot less than perhaps we expected based on FOLFIRINOX study. So that study, the NAPOLI-3 trial, was the first head-to-head trial of two different chemotherapy combination regimens, showing superiority of the, let's call it 4-drug combination of NALIRIFOX in that case over Gem/Nab-Pac. And that was the first study to demonstrate that in a randomized phase 3 context. And provides, I think, necessary randomized data for practitioners who treat patients. Should I move on to the second case?
Well, let's just stop for a second and talk a little bit about NALIRIFOX first. So one question I had was, what went into the decision to use Gem/Nab as the comparator? Was any thought given to comparing it to FOLFIRINOX or even making it a 3-arm study?
Yeah, I mean, when we think back now, the time the study was designed a few years ago, there was no question that Gem/Nab-Pac was used just as frequently as FOLFIRINOX, and was widely recognized as the standard. We had not had, and we still don't have, FOLFIRINOX versus Gem/Nab-Pac combination head-to-head comparisons. In my view, we should have done that study a decade ago, but that study wasn't done. And so we're, thinking about it now is a little different. And by that, I mean that everybody thought Gem/Nab-Pac would be just as good as FOLFIRINOX. I think cross-trial comparisons now are easier to think about, but that's a hindsight question in some ways. So at the time, Neil, we really wanted to answer one fundamental question, which is this 4-drug regimen better than a 2-drug regimen? And adding a 3rd arm of FOLFIRINOX would have added a lot of complexity to the study design. It also would have made it much larger.
So I guess the other question is, at this point, first of all, not also based on the data and also your clinical experience globally, how would you, at this point, and maybe I'm sure there's going to be maybe more data coming along, but at this point, how would you compare tolerability, side effects, and quality of life, NAB/Gem versus NALIRIFOX?
I think that overall quality of life and toxicity profile favors NALIRIFOX. Some of that quality of life data will be coming out over the next year or so. But I mean, I think overall that if you learn to manage these regimens, which I think now we're pretty comfortable doing, the toxicity profile is just as manageable, if not superior. I find that the GI toxicity, we've gotten a little better at handling this last few years, both with NALIRIFOX and with FOLFIRINOX. And so prophylactic management, dealing with improved GI toxicity is one angle we've gotten better at. And we've also gotten better at, limiting doses of oxaliplatin, which is one of the key toxicity angles to any NALIRIFOX combination. So, that's been an advantage, I think, of that regimen. As far as Gem/Nab-Pac goes, I mean, at the end of the day, I think it's an active regimen. It causes side effects that are sometimes less desirable, like alopecia and others. That is not the case with FOLFIRINOX or NALIRIFOX. And at the end of the day, I think it's less active. So, improving symptoms and of the disease are very important in pancreatic cancer. So that's the way I look at it. But it is a trade-off with toxicity. It's a discussion.
So another issue is, of course, there's no direct comparison, but what's your best estimate of the efficacy, relative efficacy of NALIRIFOX, modified FOLFIRINOX, and original FOLFIRINOX?
Yeah, it's a good question. I think these are all cross-trial comparisons, of course. And I don't think people use that much original FOLFIRINOX anymore. And I think that that's a point that's been made, a good point. It's like, well, we don't actually use that regimen that much, and that's fair. I think that a lot of people find that the adjuvant modified FOLFIRINOX regimen is the right FOLFIRINOX regimen to use, and I concur with that. I think probably there's probably some subtle differences here and with respect to dosing and with respect to things like peripheral neuropathy. But, you know, we don't have the head-to-head data to compare efficacy. I do find that the toxicity is probably slightly less in my experience with NALIRIFOX, but it's very hard to you know, appreciably notice a huge difference.
In your own mind, do you consider the modified FOLFIRINOX and NALIRIFOX about the same efficacy, or do you think that one's a little better than the other?
You know, it's hard to know. I share the angst of this question that is commonly asked. I find that there's probably very similar efficacy if we're being candid, but there's no randomized data. And I actually value having randomized data in this field. I think that we can't understate sometimes how, you know, we don't have the head-to-head study of FOLFIRINOX, so we're making our assumptions completely across historical and cross-trial comparisons, which, you know, people ask and say, hey, of course FOLFIRINOX is better than Gem/Nab-Pac. Well, that was an obvious question. And I'm like, well, I don't think so. I candidly, Neil, I think that when we launched this study, if you would ask people, they'd said, no, it's too hard a disease to show an improvement in survival of one chemo regimen over another. That's why we haven't had an overall survival endpoint met in this cancer in over a decade. So I think now people are like, well, of course FOLFIRINOX is better than Gem/Nab-Pac, and you could absolutely extrapolate this NALIRIFOX data to FOLFIRINOX. And that's where I sometimes am not sure, to be honest. I'm not sure we should be doing a lot of extrapolating in this disease. Not in a disease that has run into failure after failure after failure in phase 3 trials. So, you know, I'm not sure is the short answer. I value that we have randomized data, and that's what this NAPOLI-3 study did provide.
You showed a graphic or an algorithm where over age 80 patients don't get FOLFIRINOX. What, you know, I know that's a little arbitrary in terms of just picking an age, but what about NALIRIFOX? You also would not want to use it if somebody's 80 years old?
No. Actually, so I think it's an outdated algorithm. I think performance status trumps age. In the NAPOLI-3 study, we had about 30 to 40 patients who were over the age of 75 enrolled. And there was no difference, if you look, very small numbers, of course, in that group of patients, but they did just as well or just as poorly in either arm, independent of age. So there is no, and that included patients, a few patients at least, if I recall, over 10 above the age of 80. So I think that with the proper supportive care, if you have a highly functional patient over the age of 75 or 80, and that includes sometimes use of growth factor support, and that includes dose adjustments that are being made in the real world, I absolutely think it's a viable regimen for that patient and would not restrict it just based on an age cutoff. And that is one thing that we particularly made sure that we didn't restrict the study to age cutoffs. We also didn't restrict it to, so another, just out of interest, another exclusion criteria in the original PRODIGE trial was they couldn't have ascites. And ascites, not, you know, clinical ascites, pretty common in this disease by the time patients present, as you know. And so they had a harder cutoff because they wanted a better patient population. And it was an academically inclined study, and that wasn't the real world. And so this study much more reflects the real world. There was no exclusion for ascites or age, or, you know, represented, in my opinion, a more real world type of scenario as opposed to the original Prodige FOLFIRINOX experience.
So I guess the real question here is your preferred first-line regimen NALIRIFOX at this point?
Well, I'll go either way. I would have no problem using NALIRIFOX. I would probably have no problem using FOLFIRINOX. If they're all going to be all sort, we have to wait and see if the regimen gets approved for starters. But the reason to do the study, it comes down to me to answer questions for the community. That is sometimes the most important thing we can do in this field, is not test new drugs that are, long shot drugs just because we think it might work in this disease. I think we've been doing that for far too long. Not that we shouldn't try new drugs, we always should, but we also have to balance that with answering questions. And so at the end of the day, if people come out of this saying, gosh, we'll use NALIRIFOX or we'll use modified FOLFIRINOX, I think both of those are acceptable.
What about, are there patients where you would prefer GemNab versus either FOLFIRINOX or NALIRIFOX?
Yeah, I mean, there I think, performance status is still a variable, and there's advantages to not having to put a portacath in and not doing the infusional 5-FU. I think my use of GemNab-Pac has gone down a lot in the frontline setting over the last few years as I've gotten more comfortable with modified FOLFIRINOX and predictable toxicity that it encounters. I've gone to less GemNab-Pac, and I think this study sort of cements that for me. I do use GemNab-Pac on occasion, and that certainly is usually less poor performance status and other scenarios that would preclude the use of a 4-drug regimen.
In a way, I'm trying to think about, I really admire the idea of trying to help out people in practice, but I'm not exactly sure what the message is from this study based on what you're saying. Can you sort of distill it down? What is the message? I mean, I know it's another regimen, but is there an advantage in your mind over modified FOLFIRINOX?
We don't know. I mean, is the God honest truth? We don't know if there's an advantage of NALIRIFOX over FOLFIRINOX. So we shouldn't be answering it that way, I don't think. I think the main take-home message of the study is move GemNab-Pac to second line. That, to me, is the main message for the community. If I was to distill it down to one sort of simple thing, is in an ECOG performance status patient, it's adequate and can handle 4-drug chemo, use NALIRIFOX, use FOLFIRINOX, just don't use GemNab-Pac. That would be, I guess, one relatively simple message that I think the study showed. I think the market and a lot of the cost issues and whether NALIRIFOX gets approved and all that stuff, I think all that stuff will sort itself out. Hopefully it's a springboard for adding new drugs to either NALIRIFOX or FOLFIRINOX and moving away from GemNab-Pac as our base. That would be something that I would hopefully look at as, an impact. So what's interesting, Neil, is that you've seen this shift, and now, phase 3 studies used to be GemNab-Pac as the base. For sure, we're never combining with FOLFIRINOX. We're never combining with NALIRIFOX. We're worried about this toxicity profile. We're worried about the combination. And I think that's the part of this that I think we need to change also. I think there's this illusion out there that somehow GemNab-Pac is an easier, more tolerable regimen than either NALIRIFOX or FOLFIRINOX. And I do not think the data supports that at all, actually. It's a different toxicity profile, but it's not easier. And it's not necessarily a better combination partner moving forward, in my view.
So then, even before this data was reported, it sounds like you were sort of, not going to say anti-GemNab, but not preferring it as much as people in the community.
Yeah, I think that over the last 5 years, we've seen more data with it in the adjuvant setting. That certainly helped a great deal when we started to see that data. We've got a better handle on toxicity, quite frankly. And so yes, I think there has been a gradual move in that direction from a lot of academics, and we didn't have the head-to-head study, right? So we the field is lacking in randomized big trials, actually, in some ways, even though there's so many patients. So that was the intent of this.
Very interesting. All right, let's hear about your second case, a 76-year-old woman.
Right. So this is a 76-year-old woman with progressive epigastric pain. The tumor here on the CAT scan was identifiable in the tail, mostly in the tail of the pancreas, with also synchronous metastatic disease and retroperitoneal nodes. A biopsy confirmed adenocarcinoma. The tumor marker of CA19-9 was elevated at nearly 2,500. This patient was started on Gem/Nab-Pac. This is an older case of mine. I think nowadays I would personally not start this patient on Gem/Nab-Pac, as I mentioned. But this patient was started on Gem/Nab-Pac and demonstrated a nice response with a 60% decline in CA19-9. Repeat imaging showed, unfortunately, a quick resistance, and such that 4 months into the regimen, the patient had started to progress and liver lesions were growing, and the tumor marker went up and the pain got worse. She was highly functional still, had grade 1 neuropathy from nab-paclitaxel, but had an adequate performance status. The NAPOLI-1 trial had been available at that time, and she started second-line therapy with the NAPOLI-1 regimen, which was infusion of 5-FU and liposomal irinotecan, and had a 30% decline in her tumor marker, clinically improved, no response by RECIST, but clinically improved and disease stabilization. The patient was doing overall quite well. And so she was maintained on that regimen for a period of time before ultimately progressing again on second-line therapy, and then her performance status did decline and ultimately was placed on hospice care. The patient had a survival of approximately 1 year from the time of diagnosis, which is still a big struggle, obviously, in this disease. When it comes to second-line therapy and beyond frontline therapy in this disease, we have had incredible struggles with new drug development for a bunch of reasons. Clinical deterioration has limited patients when they progress with pancreatic cancer. As we all know, they often progress in a very aggressive manner, limiting their ability to tolerate or handle intense chemotherapy. We haven't even had any regimens approved before 2015. Survival has been in the 4 to 5 months range historically. And there have been dozens of trials with novel drugs in that scenario, which have shown no significant improvement over chemotherapy backbone. The NCCN lists a number of second-line options, depending in large part on what was received in frontline. As you can see, this a bit of two columns here, but if you receive gem-based therapy, the principle here is get some 5-FU-based therapy in second line. We'll talk a little bit about those options. And if they got 5-FU-based therapy, get gem-based therapy in second line, which include any number of options depending on performance status, patient characteristics, and genetic markers, of course, like BRCA. So the NAPOLI-1 trial really was one of the first large randomized second-line trials in pancreatic cancer that enrolled patients who had gem-based therapy to one of 3 arms, either 5-FU alone, or 5-FU and liposomal irinotecan, or liposomal irinotecan alone. And the study was powered for an overall survival improvement. The single-agent arm of liposomal irinotecan did not perform as well as either of the other 2 arms, so that was not part of the primary analysis. The primary analysis showed an improvement of survival of the combination of 5-FU and liposomal irinotecan over 5-FU alone, with improvements in PFS, modest improvements in response rate, and overall survival improvements of also about 2 months that were statistically significant. The trade-off of toxicity here is primarily with an increase in GI toxicity, particularly diarrhea and nausea. And this became ultimately the first FDA-approved regimen in second line for metastatic pancreatic cancer. As you can see here in the safety table, as mentioned, it's more GI toxicity with the 2 drugs over 1, and certainly more cytopenias and bone marrow toxicity as well. Since that time, that was 2015, people have said, well, gosh, what about FOLFIRINOX? And there haven't been any randomized trials of FOLFIRINOX in second line for a bunch of reasons. There's a small trial that was actually done in Korea, which compared FOLFIRINOX in second line versus S1, which, as we know, is not available in this country, but is a standard chemotherapy drug in Southeast Asia. And it also suggested improvements in survival. Small study, again, randomized phase 2 study, not really powered, but certainly trended towards clinical endpoints of improvement, which were somewhat significant statistically, although again, not powered for that, but the improvements in survival were there. If one takes a step back and says, well, what about other 5-FU-based therapies in second line? If they get Gem/Nab-Pac, what about FOLFOX, or what about CAPOX? And you can see there have been 2 randomized trials of looking at second line 5-FU oxaliplatin-based studies that have shown conflicting results. Both of these were compared to 5-FU alone. One of these was called the CONCO 003 study, which was a regimen called OFF, but essentially was oxaliplatin and 5-FU versus 5-FU. And the other one was the PANCREOX study, which was a more classical FOLFOX versus 5-FU, and very, very confusing results. One suggested benefit, one suggested no benefit. Again, small studies, underpowered, hard to answer the question, certainly not providing clear guidance as to, is FOLFOX an optimal regimen in second line in Gem/Nab-Pac prior treatment? So not really clear as to, is this the best thing to do? It did sort of come before the Napoli trial around the same time as Napoli-1 trial, so reinforcing perhaps the importance of irinotecan or liposomal irinotecan in that context of second line. Maintenance concepts are something important in this disease, in my view, because a lot of patients do get some disease control in frontline therapy, but can't continue because of tolerability issues on chemotherapy. So the NCCN and has published some guidance and recommendations to this effect, which include, if you're on FOLFIRINOX, consider dropping out the oxaliplatin and maintaining a FOLFIRI type of regimen, or if it's NALIRIFOX, maintaining a NALIRI type of regimen, which was done in the Napoli-3 trial. If you're on Gem/Nab-Pac, consider modifying the schedule to biweekly instead of the 3-on/1-off regimen, which isn't tolerated very well for very long, or dropping the Nab-Pac if the neuropathy is an issue. And of course, the POLO trial, which looked specifically at the maintenance context in a specific patient population of BRCA 1 or 2 carriers. And that's where PARP inhibitors have a role, certainly. Should I move on to case study 3, Neil?
Yes, please.
Okay. So case study 3 is another patient of an 80-year-old with weight loss and fatigue. This is probably the most common patient I see in the late 70s, early 80s. Not clear dramatic pain, but sometimes weight loss and subtle symptoms and signs. And a CAT scan's done, and they have a big pancreas mass and metastatic disease. So we find that 60% of the time the patients are diagnosed with metastatic disease, particularly if in older patients. A biopsy confirmed adenocarcinoma, and the tumor marker was very elevated, 85,000. Sometimes these tumors make extraordinarily high CA19-9, as we all know, and that portends a poorer prognosis. This patient had NGS done that showed microsatellite stable tumor and point mutations seen in KRAS G12D and P53. A pretty common, I would say, upwards of 80 to 90% of patients will have a molecular profile that falls along those lines: KRAS, P53, sometimes P16, and that's been a very classic genomic characterization of this disease. Actually, this patient was started on modified FOLFIRINOX and tolerated quite well. We did start at a lower dose of irinotecan, which is a modification that a lot of people use, of course, and eliminating the bolus entirely, which is much more, in my opinion, sensible in this disease. The initial scan showed a PR, and the tumor marker went down nicely, but unfortunately, by 4 to 6 months in, she had started to progress clinically and by tumor marker. She had grade 1 neuropathy, but otherwise was highly functional. So here we ask ourselves, well, what is the data for second-line treatment with gemcitabine and nab-paclitaxel in post-FOLFIRINOX patients? So, you know, there is a few studies that I've listed here that are small. All of them are small. Some of them are retrospective, some of them are prospective. All of them are single agent. We don't have large randomized trials of gemcitabine and nab-paclitaxel in second-line pancreatic cancer. I think it's we do it, and that's our standard de facto approach, but we're actually missing a lot of good data for that scenario. Response rates range here between 10 and 20%, and PFS ranges between 3 to 5 months, roughly, which is, I think, in line with what we see in the real world. We don't see much higher than that second-line response rate or PFS much better than that in any study in GEM-NAB-PAC. So this is supportive, albeit a little disappointing we don't have bigger studies, but supportive of, in my view, using that regimen in second line. There have been one real-world study that has retrospectively looked at this context, and it included real-world scenarios of about 400 and something patients, half of whom got GEM-NAB-PAC, half of them got GEM alone. You can see there is an improvement in survival, PFS and OS, again, a few months, median PFS improvement of about a month, response rate slightly increased, disease control rate increased. So again, real world study, it's biased, it has all sorts of biases, particularly with respect to who got which arm. But it is the best data we have, and so I do think personally it is supportive of this regimen in second line. There have been older studies which have tried to look at, this isn't GEM-NAB-PAC, but it's GEM-PAX, which is gemcitabine and paclitaxel, which we don't use a lot of in this in pancreatic cancer. But again, this is a little bit of an older study, but at least ask the question in a prospective manner of whether this is superior to gemcitabine alone. And this was in patients who got FOLFIRINOX when failure or intolerance, and had a decent number of patients in a 2-to-1 fashion. You could see here, again, in a PFS, primary endpoint, there was an improvement in PFS of about a month, which is very similar, perhaps, to the real-world evidence studies cited earlier, with a hazard ratio of 0.64. And you do see, obviously, a little separation here of these curves, and then before they come together, unfortunately. But suggestive of, this is not GEM-NAB-PAC, of course this is GEM-paclitaxel, but suggestive of the concept, at least, of adding a taxane to gemcitabine therapy in second line. Response rate went up, PFS went up, toxicity went up, of course, consistent with the cytopenias that you might expect with a taxane. but generally speaking, the survival was not that different. Again, no difference if you look at the overlapping Kaplan-Meier curves and overall survival, which shows the real challenge of this disease, which is even if you can demonstrate a mild or moderate PFS improvement in second-line pancreatic cancer, it's going to be very hard to show an overall survival improvement, and because the patients who do get that mild PFS just progress so quickly, unfortunately, when they do progress. So no clear improvement in overall survival. Again, not the primary endpoint of the study, but worth mentioning.
So a few questions. First of all, 93-year-old person without significant comorbidities, performance status of 0, reimbursement issues aside, what's your likely first-line therapy, metastatic disease?
93. Well, 93 is pushing it for FOLFIRINOX. I'll concede that point, Neil. I'd probably use a Gem/Nab-Pac in that scenario, or a very, very modified FOLFIRINOX regimen. I have used it in a 90-year-old, I confess. And I think it's really a discussion of how good that 93 is and what they're asking for, right? I mean, it's 93 and, we have a survival of a year in this disease. If the patient's symptomatic and has a lot of pain, I think giving a few months of chemo can palliate that. So I still treat that patient by and large. But I'm not blasting that patient with multi-agent chemotherapy most of the time. A 93-year-old patient with pancreatic cancer is a tough situation. We don't treat that many nonagenarians for pancreatic cancer, but I usually take it very easy on that patient. Don't use multi-agent chemotherapy. So either Gem alone, just for palliation, sometimes 5-FU alone, but I don't, we're not going to pound away with either Gem/Nab-Pac or FOLFIRINOX with that patient.
So another question is, why is it that NAB is used and paclitaxel is not used? Was it just that the studies were done with NAB, or is there actually clinical data that it works better?
I mean, there's no head-to-head comparisons to my knowledge, but Gem/Pac had a randomized phase 3 trial in the 90s, I believe, compared to Gem that did not meet its primary endpoint. And so that was discarded. And then nab-paclitaxel was developed and met its primary endpoint. So I think that's what it boils down to. I mean, there's obviously scientific differences between the drugs. And, in some ways, it's not that dissimilar to what we're dealing with FOLFIRINOX and NALIRIFOX, where a different modification of the drug may work better. That is the point that is worth considering. The Gem/Pac trial was done so long ago that, studies were very different back then. And so, who knows if that was done today.
So if you could advance to the next slide. So I imagine you're familiar with this phase 2 study?
Yes. I mean, I've been reading about this study, and I've been reading about the treatment over the last few years, particularly in lung cancer and other cancers.
Right. So, there's a lot of mystery about the treatment. We actually found a medical oncologist. His last name was Patel from MD. We actually had him on a webinar just to talk about what he thought was the mechanism of action, because I never understood it. And you wrote all these really cool papers. But anyhow, the real question I wanted to ask you is, what do you think about this study? Do you think it's a reasonable study? Would you put a patient on a study? Or I don't even know, maybe, is it available at your place?
So we did not open this study. I think it's worth asking the question. It's so that the study design is non-metastatic. It's locally advanced disease. It's patients who aren't going to be resected, and their survival with local advanced disease is by and large, let's call it, slightly better than metastatic disease, and maybe 6 months, depending on which study you look at. And it really, I think, fundamentally is asking a question about local therapy, which is still a challenging space in locally advanced disease. By that I mean the randomized phase 3 trials with radiation, the older trials, didn't clearly show that we should be doing this in every locally advanced patients because the survival outcomes are not necessarily better. It may improve local control. It may improve some symptoms, but and it may reduce the risk of local recurrence, which is a bit of a misnomer because they already have the disease locally, but just may progress locally, I guess would be the way I would phrase it. But does it impact long-term survival is unclear. And so this trial is a, let's call it a newer way to ask the question of local control in this disease. So I think it's very reasonable. Logistically, we had trouble with this study. I think it's, you have to wear the patients have to be wearing this thing for about 16 to 18 hours a day on their abdomen and wrapped around their shoulder like a harness. So it's not a logistical easy thing for the majority of patients in my experience. So, and I had some experience with this in other cancers. So personally, we did not open the study at our center. I would have no problem, though, if a patient wanted to open or enroll in this kind of study, doing this kind of study. I am curious to see the results, like everybody, particularly the overall survival results, to see if a more aggressive local therapy would impact long-term survival of this disease is a real interesting question.
So the reason I'm asking is, I don't know if you know, but there was a big phase 3 trial presented in non-small cell at ASCO using tumor treatment fields. And the reaction of one of the reactions from the investigators was that the control arm that they picked, or the actual, thing that they compared to adding, they felt was outdated. So the trial was actually positive. There was a survival benefit, but people are more focused on, like, what does it mean now because these people didn't get standard therapy? And that's my question here. So for example, would you be comfortable using GemNab in the control arm of this study in a patient in this situation?
Right. So it's a good question. I think, if I'm not mistaken, in non-small cell lung cancer, it's centered on an immunotherapy question, which is, a big advance, obviously, in non-small cell lung cancer, particularly among certain patients. So maybe there the question is even more relevant. I think personally here, that's less important to me in some ways, because the context of this is an addition of a local therapy to chemotherapy, is conceptually a more important variable in this disease maybe than in non-small cell lung cancer, where the chemo combinations, there is difference, as we talked about earlier, better survival, but is it that much different? So, for example, Neil, if this study meets its primary endpoint and improves overall survival, not just progression-free survival in this disease, I think that's something that we would seriously consider, regardless of what chemotherapy backbone the study control arm was done. It will raise the questions, of course, but trials that meet primary endpoint for overall survival in this disease are so few and far between that they shouldn't be ignored, in my view, regardless of what the control arm is.
Well, that was my question here, but I guess so. For example, if these are people who are not resectable but localized, correct?
Correct. They don't meet criteria for resectability or even borderline resectability. They have no metastatic disease at entry. They have no macroscopic disease at entry. We know that a large percentage of patients will metastasize very quickly, and all of them probably have micrometastatic disease. But we're talking about patients who have full vessel involvement that disqualify them from any potential surgery. At least that's the way locally advanced is defined.
So in general, how would you manage a patient like that?
That patient is managed, in my opinion, for the first 6 months the same as if they had metastatic disease with combination chemotherapy, and in my practice, that's FOLFIRINOX, NALIRIFOX maybe, or Gem/Nab-Pac, depending on the age, performance status, and all those variables. At the completion of 6 months, though, the difference is, unlike metastatic disease where there's good data to support continuing therapy, here there's not sure what to do with those people, is the way. The randomized trials have been mixed. There's no clear survival advantage to continuing chemotherapy beyond 6 months in these patients. And so what you see is all over the map. You see some people at that point doing radiation therapy because they're, hey, this is a tumor that's big and bulky and we want to treat locally. You see some people doing maintenance chemotherapy in that patient population, which was suggestive of possible benefit in the French trial. But there is absolutely no definitive standard of care of what to do with these patients, in my opinion, beyond 6 months. And so there is a vacuum there. And so maybe the study helps in that regard.